Okay, so just some disclosures. I have some research funding from Quest Diagnostics, and then I have some grants from the other organizations listed here. So the first half of the talk, I'll focus on MCI and dementia diagnosis in everyday clinical settings like primary care, and that's the Brain Health Assessment Project. And then in the second half of the talk, I'll focus on supportive dementia care for patients and caregivers, the Care Ecosystem Project. So starting with the diagnosis, more than half of people with dementia in this country are either undiagnosed or unaware of their diagnosis. They haven't been told by their provider. So this is a major gap in care because without diagnosis, families miss the opportunity to treat reversible conditions, to optimize their medications, to inform treatment decisions for other conditions in the context of a neurodegenerative disease, connect to support services and education around what's happening, opportunity to participate in clinical trials and other research, address safety issues, engage patients in planning ahead for their care while they're still cognitively able to participate in that process, and missing out given the promise of new therapies on the horizon. So, and certainly when we have better therapies, better pharmaceutical therapies, this earlier diagnosis is going to be an even bigger need. Now, primary care providers are often in the best position to spot the early signs of cognitive decline. And here's an illustrative quote from a caregiver. "We've been going to our PCP for a long time, so we feel very comfortable with her and the practice in general. She's always concerned about both of us. It was natural that she was the first person we talked to about his memory problems." Both primary care providers and seniors perceive brief cognitive assessments as important. So in this recent study by the Alzheimer's Association, they found that 94% of PCPs rated brief cognitive assessments as either somewhat important or very important, and seniors 82%. Despite this perceived importance, they really aren't being used very often. So you can see here that 18% of seniors report that problems with memory or thinking are evaluated for or dealt with on a regular basis by their primary care provider, in contrast to these other conditions. So, why aren't PCPs, assessing for cognitive disorders more often? Well, perhaps one of the biggest reasons is that they don't feel they have enough time. 58% of PCPs cite this as a reason for not assessing brain health. And in one study or simulation, a PCP with 2,500 patients would need 22 hours per workday to provide all the recommended preventative and chronic disease management services, every specialty pushing PCPs to do more. So we have to recognize that PCPs are often very stretched thin. They're also dissatisfied with the brief cognitive assessments that they use today. So 9 out of 10 PCPs report that they sometimes use one or more brief cognitive assessments, and you can see the most common ones here on this list. And 77% of them consider the structured testing not definitive enough to make a diagnosis. So in a recent study of 100 PCPs, a fellow in our group found that 20% of PCPs reported high confidence in their ability to interpret cognitive testing results. So 80% of the PCPs felt that they had a gap in this area. They also, only 21% were highly confident that they could recognize when a patient had a neurocognitive disorder. And if you looked at the patients who had lower confidence around these skills, those are also the ones who were less likely to then evaluate and care for these patients. So addressing confidence is also a need. Okay, so primary care providers report that they want more guidance on cognitive assessment, including which assessments to use and the next steps to take when cognitive impairment is indicated. And I think a limitation of most of the cognitive assessments out there is they don't then provide guidance on next steps. And so primary care providers think, well, why am I going to do this? I don't have anything to do for my patient if I detect cognitive impairment. So a cognitive assessment needs to include those turnkey recommendations for providers. So that was some background on the project that I'm going to tell you about called the Brain Health Assessment Project. And we developed this assessment for the efficient detection of MCI and dementia in everyday clinical settings. I'm saying primary care here, but really you can think about a pre-op clinic with older adults, the emergency department, or other everyday clinical settings where efficient detection could improve care. So this assessment takes 5 to 10 minutes. It's comprehensive in that it efficiently samples each of the major cognitive domains. And has automated scoring and provider feedback. So the second you finish administering the test, you have a text-based summary report of how the patient did and the next steps in care. And this report at UCSF instantly populates in Epic. And all the tests were designed from the very beginning to minimize cultural bias to the extent possible. And I want to emphasize this does not replace a neuropsychological assessment, but might help a provider know when to refer to a neuropsychologist, or oftentimes, unfortunately, neuropsychologists are not available. I hope to convince you that the best interface for brief cognitive assessments is the tablet, like an iPad. Most neuropsychological assessment is paper-based, but computerized testing offers numerous advantages. It's a much more standardized administration. The stimuli can be dynamic. You can precisely capture responses, including reaction time. And then, of course, scoring can be automated, and you can use advanced scoring procedures. You can also adapt stimuli difficulty to the patient's performance. So on a trial-to-trial basis, if they're doing well, things can get harder, or if they're doing poorly, it can get easier. So in that way, you can be more efficient and precise. We also find that the tablet-based interface is comfortable, even for older adults who have never used computers or smartphones. So that doesn't seem to influence performance. And even older adults who have very, very low education, who've immigrated here from other countries, feel comfortable more so than they would with a paper-based interface. So these are the key components of our brief assessment, which, as I mentioned, takes 5 to 10 minutes, depending on if you just do the core components or if you do the whole thing. So we have a test of executive function, and I'm going to show you a little bit about what some of these tests look like in a moment, but this is our test of executive function based on the classic digit symbol paradigm. We have a test of associative memory that's very hippocampally dependent. We have a test of visual spatial skills where you judge the orientation of lines. Our language test is animal fluency. It's not maybe the optimal language test, but what I like about it is it's 1 minute and it works well across different languages. And then we have an optional informant survey, which asks the person who knows the patient well, maybe the spouse or the child, about changes that they've noticed in memory and other thinking skills. It's only optional because informants are not always available, but if they are available, it really improves the accuracy of the assessment. So our tasks are now in 17 languages. So this is these are screenshots I'm going to show you now of TabCat. So TabCat's our software platform that we use to deliver the brief health, this assessment I'm telling you about now, but also we have a lot of cognitive assessments on TabCat. So it stands for Tablet-Based Cognitive Assessment Tool. So I'll show you a little bit about what it looks like. So you can just go into this menu screen to choose your language. And I'll show you first the test of executive functions called MATCH, that, as I mentioned, is based on digit symbol. So look at the boxes above. Each number has its own picture. Now look at the pictures below. They match the pictures above. Each time you see a number in the middle of the screen, look to see which picture matches the number, and then touch that picture below. So for example, here, the patient would touch this button. So it's a very simple task, but it's very sensitive to changes in cognition. So now I'm going to show you a test of memory called favorites. And these are actually not the real screenshots from the favorites task, but it looks like them. So you will need to remember people and their favorite things. For example, remember that her favorite food is an apple, and her favorite animal is a dolphin. So what was her favorite food and animal? Very good. That was your practice. Okay. All right, and so now you'll see some more faces. You'll see each face twice, once with their favorite food and once with their favorite animal. Remember both. Are you ready? Okay. So what was his favorite food and animal? Great. So that was kind of a mock version. The actual version has slightly more stimuli to remember, and you have 2 learning trials and then a 10-minute delayed recall. So this is the visual spatial task. The patient just touches the orange line that's parallel to the white line. So here the patient would touch this one, and this one adapts the difficulty to how the patient's doing. So very quickly, like within a minute, we can get a very precise estimate of their judgment of line orientation. You can compare that to the traditional way of assessing this test, where you give the same 10 or 20 trials to every patient, irrespective of how bad their visual spatial functioning is. So this is, I think takes less time and is more precise. All right, so I gave you a sample of what those cognitive tests look like, and as I mentioned, there's also that optional informant survey. And so we can give the provider the scores on each of those 4 cognitive domains, but probably more important for these settings is the global cognitive score. So I'll show you data on that now. So the global score is optimized to separate people who have normal cognition from those who have a known cognitive disorder, MCI or mild dementia. And all the people who participate in our research have a very expert consensus diagnosis workup. They participate in our research. They come in for 3 days. They get every biomarker available. So the people in this research, for example, on this slide here, we know for sure that they are healthy controls or have MCI or mild dementia. So in this ROC curve, we're separating the controls from the patients. And you can see the top dark blue line. That's if you give the full brain health assessment that takes 10 minutes, including the informant survey. The dotted blue line is if you don't have an informant. And then the other 2 lines for comparison are commonly used paper-based screens, the MoCA and the MMSE. So you can see the area under the curve here. So it does improve accuracy a bit over some commonly used screens. Taking that algorithm that was derived on that English-speaking sample that was mostly moderate to high education, we've applied that same algorithm to a couple independent and very different samples in terms of culture and education, and it seems to perform almost as well. So this is a sample of Spanish-speaking, monolingual Spanish-speaking Latinos living in the San Francisco area, and this is a sample of people in Greece. And this sample only had MCI, no dementia, so it looks like slightly lower AUC, but they didn't have any dementia patients in their sample. And we have some ongoing studies in a number of other countries in the world. We have the most work going on in Latin America right now. This is in healthy controls who have had amyloid imaging. So if we compare 110 healthy controls broken by whether or not they are amyloid negative or amyloid positive, and look at their performance over 3 years on the brain health assessment, annual assessments, we see that the people who are amyloid negative show the expected practice effects over time, but those who are amyloid positive are showing some decline. So even within this very rigorously assessed healthy control sample that's participating in our normal aging cohort with no subjective concerns, we see a difference here. I mentioned there's these 3 sort of new neuropsych tests that are used in this screen, match, line orientation, and favorites. And we look to see their neuroanatomical correlates in a large sample of mixed of normals and patients with different neurodegenerative diseases using voxel-based morphometry, and found some expected correlations, which is a part of the validity evaluation. So the executive function and speed task correlates with brain regions in frontal, parietal, and basal ganglia, line orientation with right parietal, and the memory task with the medial temporal lobes, including the full extent of the hippocampi bilaterally. So that was a sort of a check to see, are these tests measuring what we think they're measuring? So when I started my talk, I mentioned that primary care providers really want to know what are the next steps in care. They don't want to just find out that the patient has cognitive impairment. If that's the case, they want to know what to do next. So that's something that we're working on now. We recently launched this web page with the 5-step brain health workup that guides the provider through how to make a diagnosis, what are the steps of the evaluation, and how to disclose a diagnosis and start the care plan, and also when to refer. So that workup, as well as the interpretive report that's automatically generated when you complete the assessment, links to educational handouts that the provider can give to the patient and family. So if they make a diagnosis of dementia, they can give this 3 or 4 page handout to the patient and family that talks about what kinds of things they should be thinking about and what are some key resources for them, like the Alzheimer's Association or the Family Caregiver Alliance. So it's not, obviously we think patients and families deserve more than this, but this is at least something tangible that the provider can hand to the family when a diagnosis is made. And so these are all available in our primary care portal that has that 5-step dementia workup. We also, by the way, since I know we have a lot of neurologists in the room, we have educational handouts here for every neurodegenerative disease that you could think of. So there's a different one here for cortical basal degeneration, for PSP, everyone has a separate handout. So if you make those diagnoses, there's something for your patients as well. So please check it out if that might be useful to you. And if you have trouble finding those on the webpage, don't hesitate to email me. We have a lot of stuff on our website, and sometimes it can be hard to find what you're looking for. All right, so that was the Brain Health Assessment Project, and I'm going to shift gears now to talking about a care program, but I'm happy to take questions anytime during this talk, so I just wanted to mention that. You're welcome to interrupt me anytime. Okay. All right, so this is the voice of a man describing what it felt like to learn of his wife's diagnosis. My doctor said it was dementia and gave me information about a support group, but that was pretty much it. I had no idea what to expect, what to do next. Janet didn't seem like how I imagined people with dementia to be, and so it was hard to believe. I remember feeling so alone. For those first few months, I was pretty much in denial. Dementia care is too often crisis-oriented and fragmented. Patients experience frequent emergency department visits and hospitalizations, multiple care transitions. Inappropriate and potentially harmful medication use is all too common. Patients receive aggressive end-of-life care that is often inconsistent with what they would want in advanced dementia. And the informal caregivers, so the spouses, the children, the other family members, they shoulder substantial burdens with minimal support from our patient-centric healthcare models. And ADRD, this is a term that stands for Alzheimer's disease and related disorders. So dementia caregivers report high emotional and physical stress due to caregiving. And you can see that the emotional stress is particularly high, with 59% reporting that it's high to very high. And this really matters not only for the patient, not only for the caregiver, but also for the patient. So even though our healthcare models are patient-centric, there's still good reason to focus on the caregiver. So in this recent paper, a new faculty member in our group looked at 663 caregivers and found that 13% had depression at baseline, and having depression in the caregiver was associated with 73% increase in rates of emergency department use. Also, caregiver burden and caregiver self-efficacy were associated with ED visit use, although the strongest relationship was with caregiver depression. And dementia is very costly to our healthcare system. It's among the most costly health conditions, and these are direct healthcare expenditures in 2011 from a seminal paper by Michael Hurd and colleagues at RAND. In a paper we just published this year, we looked at a sample of California Medicare beneficiaries, and we had a 100% sample from 2015. And we broke that sample down into dementia subtypes. So Lewy body, which includes Parkinson's with dementia and dementia with Lewy bodies, frontotemporal dementia, vascular dementia, Alzheimer's, and then other or not otherwise specified. And actually, incidentally, by far the largest category of dementia diagnoses is not otherwise specified. So 58% of the people in California who have a dementia diagnosis, it's not otherwise specified. So we compared the cost to Medicare by subtype and found the highest costs were for Lewy body dementia, followed by vascular dementia. And we also looked at drivers of those higher costs in Lewy body versus Alzheimer's and found falls is a really big predictor, explaining 20% of the variance, but also the psychiatric features, urinary incontinence and infection and delirium also explain higher costs in Lewy body compared to Alzheimer's disease. So those patients really need extra caregiver support. So there are a number of effective dementia care programs, really innovative programs, and I don't list them all here, but I list, I think, many of those that are the biggest focus of research right now. And you can see that there's these rigorous studies that show that care management programs and caregiver support interventions benefit patients and families. And some of them have even demonstrated healthcare cost reductions or that they are cost neutral by reducing nursing home admissions, ED visits, hospitalizations. So really some wonderful programs out there. Unfortunately, most patients are not receiving these types of care. Notably absent from that list of effective dementia care programs are those that promise to end or reverse cognitive decline by using dietary supplements or by targeting unsubstantiated etiologies of neurodegenerative disease like metal toxicity, mold exposure, or Lyme disease. And for more on that, I'm sure many of you have had patients come to you and say, oh, here's this great program that promises to end Alzheimer's disease. So this is a nice opinion paper by some of my colleagues that was just published in JAMA this year that provides some guidance to providers on how you can help your patients when they come to you with questions about these programs. But what is effective? How can we help our patients and families? Here are some components of effective interventions: care coordination, safety evaluation and strategies, behavior management, management of coexisting conditions, connection to community resources, caregiver support and education, help with advanced care planning, and interventions that are flexible and tailored to care recipients' changing needs. It can't just be a one-time intervention. Let's give you your dementia care now and send you on your way. It really needs to be an ongoing relationship as the needs evolve. So when we first started the care ecosystem, this paper was published right when we got our first big grant to develop and study the care ecosystem intervention, and it really had a big effect on me. This paper by Laura Gitlin and colleagues wrote that over the past 3 years, more than 200 dementia caregiver interventions have been tested in randomized clinical trials and found to be efficacious. Few programs have been translated for delivery in various service contexts, and they remain inaccessible to the 15+ million dementia family caregivers in the United States. So I didn't want our intervention to just live in the ivory tower with a nice publication. I really wanted what we did to get out there to patients and families. So from the very beginning of designing the care ecosystem, we were already thinking about scale. Here are some key barriers to dissemination of effective dementia care. There is always going to be upfront investments required for launch of any new clinical program, and this is just a fact, and Medicare is probably not going to pay for that. There's sustainability challenges. Although I think reimbursement opportunities are better now than ever, and Medicare is really working hard to improve them further. There are gaps in the dementia specialist workforce, huge geographic gaps, cultural gaps. So this is a big problem. I mean, I wish every patient could get in to see dementia specialists and neuropsychologists, and it's just not the reality. Also, some of those effective care interventions are designed in a way that's quite structured, and highly structured clinical trial designs and highly structured interventions may not be adequately adaptable to work in diverse health systems or with diverse care recipients. So I think it's important for, if an intervention is going to be scaled, that the intervention also has to be highly adaptable. And I think that scientists, as well as practitioners, but scientists have a critical role in bridging the science-practice gap, and I think this is something that scientists have not done a very good job at historically. So scientists need to understand why the gap exists. You know, we know these programs work well in controlled settings, but they're not being delivered to patients in the real world. And we also need to work continuously with policymakers to make sure they understand the science and they can guide practice change. So this is our sort of our roadmap that we're using to guide us from science to hopefully broad impact with the care ecosystem. So we started with iterative development to develop the care model. Then we did our controlled research, and this is ongoing. Now we're in this phase of implementation science. We're studying how does the care ecosystem work in real-world clinical settings, and hoping to move towards scale. And so we're developing the tools to facilitate scale. So I'm going to take you through this roadmap with the care ecosystem. So starting with iterative development, you know, we had some ideas for how we thought this care model should work. And most of those ideas, because of the really amazing clinicians that I work with, and this was mostly nurses, but really multidisciplinary, nurse, social work, pharmacy, neurologist, lawyer on our team who specializes in elder law. So we had a very multidisciplinary group coming together, and so we designed this program together. And we tried it out. We released it, and we started testing it on patients. We did 132 caregiver surveys, so the first 132 people enrolled in the program. We really evaluated what they liked, what they didn't like, and we listened to those caregivers. We did 3 waves of clinical staff interviews and got weekly input from our clinical staff, so listening to those care team navigators. I'll tell you about the navigators in a moment, but you know, all of our clinical staff, we wanted their input, what was working, what wasn't. We have a family advisory council. It's made up of dementia caregivers, and we had 6 early meetings with them. It's actually for this program that we developed this council, which continues to guide all of our work today. And we also did focus groups with primary care providers. So we used all of this information and then rapidly improved our program. We were guided a lot by agile principles from software development in creating Care Model Release 2.0, which has since mostly remained stable, although we continue to improve the resources that we have available. So this is the model of the care ecosystem. The care team navigator is at the center. This is an unlicensed but trained dementia care guide. And the care team navigator partners with the patient and the caregiver. So we think of them as the dyad. So when you're taking care of a family with dementia, you're really taking care of the dyad or the family, not just the patient. So the care team navigator partners with the dyad. And the care team navigator is available during normal working hours. We actually thought about doing 24/7 coverage, but we're not doing that actually. So during normal business hours, sometimes in the evenings, the patient and caregiver can reach out when any questions or concerns arise around the dementia care and ask the care team navigator. Now that care team navigator is quite trained and has access to lots of resources, so can often address those concerns themselves, but when they can't, they can triage to the dementia expert team. So our dementia expert team has pharmacy, nursing, and social work. So we always first address the immediate needs of the caregiver and on every phone call, and certainly in the beginning when the relationship starts. But as time allows, we work through care protocols. So the care team navigator will reach out to work on things like advanced care planning. And they talk on the phone on average monthly for this program, but it varies. We personalize the level of contact depending on the needs and preferences. Please.
How many dyads will a care team navigator be responsible for?
Yeah, so it varies. I would say a rough number would be 60 for an experienced navigator. We have experienced navigators who have as many as not in the low 90s. And then we also, if a care team navigator is newer or has a very complex caseload, then sometimes it's less than 60. So I'd say about 60, and the highest has been about 90. Okay, so who is a care team navigator? We look for people who are friendly, empathic, and organized, loves working with people, good on the phone, but healthcare background is not required. The CTN is trained. They go through a training program. It takes about a month, and they're supervised and supported by their clinical team. And the CTN provides telephone-based care coordination, education, and support. We have 4 major areas of care, so I'll tell you about them. Medications. So the CTN will review and monitor patient medications. Actually, I should say the team will review and monitor patient medications to make sure they are safe and effective. So the care team navigator actually reconciles those medications, talks to the caregiver, finds out what the patient is really taking. We find a lot of discrepancies between what's in the EMR and what the patient's actually taking. And then a pharmacist reviews the medication list for all patients at study entry, and then when certain new prescriptions are added, the pharmacist gets involved again. And the CTN checks in about monthly about if they're having any problems with medications or accessing medications. Caregiver support. So the CTN will offer suggestions and advice about caring for the patient, will provide customized caregiver education support and community resources. And so we have a library, it's called the Dementia Curriculum, that has all kinds of resources that the care team navigator can use and also can even give directly to the patient. Decision making, this is where advanced care planning comes in, so providing support and resource links for medical, legal, and financial care planning. One of the first things that families are usually surprised to learn is that Medicare is not going to pay for institutional support or long-term care support. So it's really important that patients and families plan ahead for the financial challenges as well as the medical and legal challenges. Behavior, this has been a really important area. It wasn't actually such a big area of our program when we first launched, but in that iterative development process, we learned that this was a huge need for caregivers. And so we coach and advise caregivers on strategies to manage behaviors like wandering or agitation while promoting safety and quality of life. So I told you a bit about how we developed the care model and a little bit about what the care model looks like. And so now I'll tell you about some of the controlled research that we've done. So this is a randomized controlled trial that was funded by Centers for Medicare and Medicaid Innovation. So we received referrals from the community and from physicians, and then we performed our survey with the caregiver. Took about 45 minutes over the phone. And we didn't even meet a lot of these patients in person. In fact, most of them we didn't. So even the consenting was done over the phone in DocuSign. Then we randomized the dyads. The dyads were randomized to either the treatment or usual care in a 2-to-1 ratio. Then the people who were randomized to the intervention, they were assigned a care team navigator. And that care team navigator reached out and told them they were in the treatment group and began to address their immediate needs. As I mentioned, we did a satisfaction survey on the first enrollees, and then we did the main outcome survey on everybody at 6 months and 12 months. So here are the care protocols, and the order and the dosage of these protocols was adapted for each dyad's needs. Our eligibility criteria are quite loose. I would call this a pragmatic randomized controlled trial. We wanted to really approximate what's going on in the real world. So they had to have a diagnosis of dementia by any treating provider. they had to be covered by Medicare or had that pending. We delivered the program in actually 3 languages. This shouldn't have Mandarin. So English, Cantonese, and Spanish. So we had research coordinators and care team navigators that spoke those languages. And we delivered care in 3 states. They couldn't be in a nursing home at time of enrollment because we wanted to measure time to placement. These are the zip codes of the people who enrolled in the trial. So you can see, definitely a lot of people in these urban areas where our main study sites were located. So in San Francisco Bay Area and in Omaha, we had a hub there. But also people in rural areas. And those are the people I think I'm most excited about because these are people who wouldn't otherwise have access to any dementia specialty care. These are the outcomes we focused on. So quality of life, our primary outcome. Caregiver burden, self-efficacy, and depression. Utilization of the patient, so using hospital, ER, ambulance, doctor's visits, and satisfaction with the care that we provided. And so we've already evaluated the effect of the intervention and those outcomes after 12 months. And we actually got some more funding from the National Institute on Aging to turn this into a 5-year trial. So although we're publishing the 1-year outcomes, we're going to be able to continue to provide the care and measurement for 5 years or until patients have died. So actually over half of our cohort has already died. And we'll also, as claims data are available, I don't know if any of you guys have analyzed claims data, but sometimes it takes a while to get the claims data. We're still waiting. Hope to get it in the next 6 months. We'll be able to measure the impact of the program on total cost of care and other outcomes we can get from claims data. So this utilization data up here that we've already looked at is based on survey data with the caregiver. And then time to long-term care placement. As more patients are placed, we'll be able to look at that. And satisfaction with care around the end of life, as well as cost of care at end of life. So this is the status of our randomized controlled trial. These are the numbers that we enrolled. Our sample was quite diverse with rural and urban people, monolingual Chinese and Spanish, range of SES. And so unfortunately, I am not allowed to share with you the results of the trial. They're under embargo, but they will be published extremely soon. So I'm not allowed to even tell you the publication date, but it's extremely soon. And I will be happy to send it around if that would be helpful.
But you seem to be smiling about that.
Yeah, I mean, yes, I think it was a very successful trial and certainly something we're pushing forward with. All right. I can share with you some satisfaction data. So this is caregiver satisfaction with the care team navigator. So the care team navigator is a new role. Based on navigators we see in cancer work, but really a new role. And so we wanted to really understand what caregivers thought of their care team navigator. So you can see that 86% felt that they nearly always were listened to. 92% felt they could always trust their CTN. I thought this was interesting that 79% felt that their CTN was nearly always knowledgeable. I mean, this is somebody who came in with no medical background. So I thought that was encouraging. We recently published this paper on the costs of setting up and provisioning the care ecosystem. We hope this will be useful to health systems. And here we chart the average cost per patient per month by caseload. And so that was a really important question I got earlier about the caseload. Caseload really drives the cost. But at the same time, you don't want the caseload to go too high because that can start to compromise care, and also the navigators can experience burnout. I think as a contrast, some of those collaborative care models that are nurse-run as the first point of contact, like the UCLA model. The UCLA has a really lovely collaborative care model for dementia, but the nurses are handling a lot more in their model versus the navigators in ours, and their nurses have a very large caseload, I think over 200, and they have to really to because of the costs, I think. So with the navigators, they can spend more time with each dyad. So reminding you of our roadmap, I've told you about the iterative development, the controlled research, and so we're working now on what I would call implementation science projects. So these are health systems that have adopted the care ecosystem, and we have the opportunity to meet with them monthly, to learn about the challenges they're facing, to learn about how they've adapted the program to fit their health system. So the science doesn't stop at the trial. The science continues by learning from these experts in really providing care and from diverse health systems. So we've launched at our own clinic, and also at this clinic that's a safety net primary care clinic in the Tenderloin, which is the poorest area of San Francisco. So this one actually has a lot of homeless or nearly homeless people with dementia enrolled in. Most of them don't have caregivers, so this is a very different implementation. Allina Health was our first health partner, health system that wanted to adopt the program, but you know, they unfortunately, I don't think it's going to work out, and I think mainly because of staff turnover. The people who are really champions for it have left the program. But we have been successful in launching it at these last three, and I shouldn't say we, really they have launched it, and we have gotten to consult and observe how they've done it. So Health Partners in Minnesota, they got a grant. We actually co-wrote the grant with them from the Merck Foundation, which is a nonprofit philanthropic arm of Merck. And Oxner in Louisiana, with some, as I mentioned, it always takes some funds to launch these programs. So they got a philanthropic gift to get it off the ground. And then the University of Colorado at Denver uses Comprehensive Primary Care Plus funding from CMS to deliver the program. So all of them have a couple care team navigators with full caseloads now, and it's been really exciting to watch. They all happened to start in around June of last year. Mm-hmm.
I'm curious about your experience in terms of retention of the care team navigators,
right.
given how important I imagine that to be.
Right. It's really important. And in fact, I even did an analysis once where I looked at outcomes by whether or not there was turnover of the CTN and found better outcomes in the dyads that had a continuous relationship with one CTN. So it's been a challenge at the San Francisco hub because we tend to hire these people fresh out of undergrad. They want to go on to some medical career and they want to get some experience. They're really smart and hardworking and willing to work for a sort of a low salary in San Francisco, and you know, this is who we hire, and they work with us for 2 to 3 years, and then they go on to nursing school or medicine or something like that. So we have a lot of turnover at the San Francisco site. I will say though, we are so proud of all these young people who get inspired to be part of geriatric care, who are now going on, most of them, to pursue careers in taking care of the geriatric population. So although there's that turnover is unfortunate, it's also something we're really proud of because we're improving the dementia specialist workforce. In our Nebraska hub, which is our other main site of this big trial, they have had amazing retention of navigators. In fact, we've had to let so many of them go because the people have died and we don't need as many, but the navigators they have now have been there from the beginning. So they get people who are more career navigators, different ages in life, and so it's interesting, and I think you have to look at, well, who is the available workforce in your community, and think about that. But yeah, definitely if you can retain them for longer, it's better. So we're thinking about scale. So obviously, this program has not been widely scaled. It's, as I mentioned, it's at about six different health systems now. But we really hope that this type of care can be scaled. And so we are developing materials to support that process. We have a toolkit and training videos that are available on this web page here. We just launched so the toolkit is written for health system leaders who are thinking about whether this program is right for their health system. And then the videos, there's about 60 videos. They're all short videos, most of them around 6 minutes each, with quizzes. And these are training videos for the Care Team Navigator. We just launched those this month. So we're now having all those implementation sites, even though their navigators are already trained, but we're having them look at these training videos and help us improve them. So we want to keep improving these materials. So yes, the training, I told you about the training program. Here's some of the topics it covers. So I'm nearly done with the talk, but I wanted to end with a couple quotes from some people who really inspired me in this field. So this is Katie Maslow. These treatments and care practices will neither prevent nor cure Alzheimer's or other dementias, but they will help to change the experience of people with the conditions and their family caregivers, helping them to manage and cope with the difficult situations caused by the conditions and live as well as possible despite them. And Chris Callahan, who runs or is part of the Healthy Aging Brain Center in Indiana, which is a really remarkable care program. Our nation can and should do more to help family caregivers provide care in the home to their loved ones who suffer from dementia. Building a system of care requires excellent science and engineering, but we also need creative approaches that design systems of care that are available nationwide because they are scalable and affordable. And most importantly, families need our help now, and we need to move faster. I want to, thank some of the key investigators that have been part of this project, both the TABCAT project and the Care Ecosystem, our project managers, and our clinical team. And here's some web pages. If you want to learn more, we'd love if you'd check out some of our web pages for TABCAT or the Care Ecosystem. This is a consortium of projects focused on the earlier detection of cognitive impairment, Detect CID. So thank you for having me, and I welcome any additional questions or comments. Yes?
What's the cost associated with TABCAT? Is it for patients or is it fixed cost?
Well, it's our goal to provide it for free. So far we've been successful at doing that. I will say, so I hope we fund it by using grants, the software. And so if you want to use it, you can just email tabcat@ucsf.edu, look at our TABCAT webpage, and then you can get an account and just download it on any iPad. Now, if you want to use it clinically, there are considerations because the data are stored at UCSF, so the data syncs from your iPad to UCSF servers. No one can access your data except for you, so I can't look at the data for your patients. But at the same time, many health systems don't like you to put PHI outside your firewall. So what some health systems are doing is they don't enter PHI into the tablet, and so there's some workarounds. Like maybe you don't enter MRI number or name or date of birth, but you can still use the assessment. So if you want to learn more, I'd be happy to email with you offline. Yes?
What kind of interaction do you have with PCPs?
Right. So for the Care Ecosystem or for the assess the. Okay. Well, okay. Why don't I talk about the Care Ecosystem? Because this. So we really, when we designed the Care Ecosystem, hope to have a lot more interaction with the PCPs integrating care, but it's been hard because we enroll people from all over the states of California, Nebraska, and Iowa, so there would have been almost as many PCPs as patients in the trial. And we tried, and we do try, but sometimes that interaction isn't as much as we would like. Now, when we've done these implementation projects, they have been, for the most part, integrated into a health system, so providing care only to patients in that health system, and so then we see much better integration with the providers. Yeah. Yes, Eric.
Do the community neurologists, do they come in with the PCPs? Is there a role in all that?
Yes, and again, I'm sorry, but do you mean for the Care Ecosystem? Or yeah, okay. Yes, so it really depends on where we are. So if we were talking about the Memory and Aging Center clinic, so we have a number of people from our clinic, a dementia specialty neurology clinic, who are enrolled in the Care Ecosystem trial or now the implementation. And so then we're really coordinating care with the neurologists. The same is true for the health partners in Minnesota. That's being run out of a dementia specialty center as well. And I don't know, I think maybe that's the best place to run this type of program is in a hub with dementia specialists. including neurologists. I think that's the ideal. I think it can work in others in primary care if you have dementia specialists there, but even better if you can have it with the neurologist and really integrate with the neurology care. Yes?
So I guess you're saying it should be kind of in a set system or a set place. I'm thinking of the PCP who may be out on their own.
Yes.
Might use it, TABCAT as like an endpoint.
Yeah.
There's so many mixed dementias and complicated dementias.
Yes.
And it really helps to have a good defined diagnosis to know proper care. To even train a family differently. If there's executive functioning stuff, that's different from memory. I mean, there's so much to it.
I know.
I love the whole pattern. I'm wondering,
Yeah.
with the TABCAT, we thought it was an endpoint diagnostic.
Right. So ideally, no. I mean, we're implementing TADCAT brain health assessment in primary care around San Francisco, and there, when there's a positive screen, the patients get referred to the Memory and Aging Center. So they do get a neuro, but that's not always possible. And so there, in fact, probably most parts of our country, that's not possible. We want them to refer, but they can't always. And we actually have another project that I didn't tell you about that's I think it's a really good comment. So we have another project that's trying to address that, that's trying to help primary care providers determine what's typical Alzheimer's disease and they can manage it in-house, and what's something different and they have to refer. And so that's an ongoing research project, but that requires even more PCP time, and so I worry about the feasibility of that. But your point is very well taken, and I think ideally this is the first step in place of the mini-COG, or MMSC, and then they get more.
I've seen the screens done in the midst of medications that were temporarily impaired too. And then so
It's,
the education around whether it's an
yes, I think that's a really important point. It's ideally not the end point. Yes?
In terms of the TABCAT administration, how did you do this? Was it a patient alone in the room? Was it a physician? Was it a nurse? Was it
Yeah.
who had to be present?
Yeah. This is a question we get a lot from providers. It's a really good question. Right now, the brain health assessment requires someone to be in the room. That could be the medical assistant, for example. Maybe their medical assistant is doing blood pressure and some other reconciling medications, and they can do the brain health assessment at the same time. But it can be anyone on the clinical staff, nurse. It can be sometimes the doctor themselves wants to do it. We are in the process of developing a fully self-administered version of the brain health assessment, which we will then need to validate as well, because we get this question so often. We hear that, oh, it would be a lot easier if this could just be self-administered to fit into our workflows. And we don't know if that will work as well, but we're going to test it out. Yes.
Question is, after your 5-year trial is up, is this hopefully going to be presented to the Medicare system for reimbursement for such care? Because with our older generation living longer and longer, and I'm really approaching the point where dementia could be a consideration. And my mother had dementia, and the care involved is phenomenal. And so with so many, and they are probably one of our most challenging diagnoses is dementia and the variety of dementia, as you mentioned. So my question is it our hope to have some kind of Medicare reimbursement for this program? It's beautiful. I think it's 20 years overdue at least.
Thank you. Yes, that's something that we work on a lot, is working with Medicare to improve payment models for dementia, and with the lobbyists at the Alzheimer's Association that are really so committed to the work that you just mentioned. So there have been some really exciting developments in the last couple of years around potential billing codes that can be used, for example. So, you probably heard of the Comprehensive Assessment and Care Planning Code. There's also, I'm really excited about the complex chronic care management. This is a code that can be used for paying clinical staff, so that can include care team navigators, for their time. It doesn't need to be face-to-face at all. It can reimburse for time spent on the phone and also time spent doing other work in support of the patient. So we think that is a code that can potentially fund this type of program and cover the majority of the costs if implemented well. But it's still not enough. Their Medicare Advantage plans will be adding a risk adjustment for dementia that's quite substantial starting in 2020, up to $6,000 per patient per year, depending on their level of complications. So that's an added incentive for health systems to hold on to their dementia patients and maybe provide them with some better care that will reduce ER visits and hospitalizations. But the conversations are continuing, and I can say that I have phone calls every other week with some relevant parties to keep thinking about how we can improve the payment models. Yes?
Thank you so much for this presentation. I'm a family physician and a geriatrician in this system, and I run the Geriatrics Fellowship. And what I want to say is that I think this brings a lot of hope for the PCPs and also the specialists in this room, because I think the tools, like the brain health assessment, are one step. Training our PCPs on using these tools and then creating a system like this for the then what. When you make the diagnosis, as a primary care physician, I think you would want nothing less, for the patients and their families. So I think this just brings a lot of hope, and I hope we can look into implementing this locally.
Thank you.
I think as an observation, it's, most of these work better if you're in sort of a larger system where you can get some support from administration to put in some resources to help organize things, because most of the clinicians are relatively busy, so you need to get at least some staff support to help kind of organize these things.
You absolutely need staff support. Yeah, absolutely.
But the beauty of what you just described, to Carrie's point, is that particularly with the use of the care navigators, it's a scalable condition that isn't geographically limited, right? And when you talked about the folks that you had to lay off because they lost their patients who died, well, you can take that knowledge and experience. They're sitting in a phone center somewhere, they can apply it to whether it's Seattle or Newark or wherever. And that's the beauty of it, is that it is scalable. And it isn't geographically limited, which is really a big deal for our patients.
Right, because most neurologists and most primary care docs don't have 90 minutes to talk on someone's phone. But the navigators do have some time for that.
Right.
And that's a lifesaver.
And it may improve, we'd like to study this, we haven't, but it may actually improve access to care by the neurologists and the nurses, because maybe they're spending less time fielding calls that could have been handled by someone else.